Hi, Nathan Ritter from cardiogauge.com. I'm a cardiologist in New York. I'm talking about lipoprotein(a) in this video. I'm going to go through the basics, what you need to know about it. It flies under the radar some, and it really should not. So let's get right into it. So lipoprotein(a) is written this way. It's a little bit confusing. It's got the A in the parentheses usually. And we'll go over the basics here. I really want everybody to know about this, so that's why I'm doing this video. So terminology, the lipoprotein(a) is the same as this. This is an abbreviation for it, and you'll see this constantly. I'll use that also in my diagrams. And the way you say it is lipoprotein(a). And that's to distinguish it from lipoprotein(A), which relates to HDL. So it's pretty confusing terminology. Anyway, let's go through a bunch of factoids. So lipoprotein(a) is a type of LDL cholesterol. It's got an extra protein stuck on it. So you start with a regular LDL blob, and then this thing called apolipoprotein(a) is stuck right on the LDL. And it turns out that makes it quite different from a regular LDL. It makes it so a regular assay of the cholesterol doesn't check it. It turns out 20% of Americans have this. So it's a ton of people do have some lipoprotein(a), and that's 65 million people. That's a big chunk of people. Very high lipoprotein(a) means increased risk of heart attack, up to 2 to 3 times where a person would be at without that. So it is a very strong risk factor, and it turns out that that risk is basically equivalent to being a heavy smoker. So that gets the message home. If your lipoprotein(a) is high, that does increase risk for heart attack and stroke and all that. Like I mentioned before, it's not measured in a standard cholesterol test. So a standard cholesterol test, you get your total cholesterol, your HDL, LDL, triglycerides, but you would not get this. Only 10% of folks in the country have had it checked. A lot of you watching are probably very interested in your health, so I bet more than 10% of you guys have had it checked, but it is a small proportion of the overall adult population. Just to give you some idea, 10% know, and 90% don't know. It turns out all ethnicities are affected, more so African descent, but basically all ethnicities should think about it. Why does this even exist? Why is there such a thing as lipoprotein(a)? Well, it promotes clotting and inflammation at sites of injury. So it improves the chance of survival of trauma back in the old days. But it's not the old days anymore. It's the modern times. In modern times, trauma is far less common, so it's not advantageous to have the lipoprotein(a). It's a disadvantage. Way back then, you'd get hurt, bitten, cut, sliced, smashed, whatever. And the lipoprotein(a) would help there be healing at the site of injury, and you would live on happy. But nowadays, we're not subject to trauma as much, nearly as we were thousands of years ago. So you're sitting at your computer chilling, and you've got a bunch of lipoprotein(a) floating around, and it causes a blood clot in your heart artery, and you get a heart attack. Boom. So whether or not you have this elevated is controlled by genetics. It's not something that generally is controlled by all the other usual suspects: diet, exercise, habits, smoking, alcohol. Supplements don't really change it. Medications largely are ineffective at reducing it. So it's all genetic, which is a bummer because you like to think that you're in control of your risk factors. But when it comes to lipoprotein(a), you don't have a ton of control. In my practice, I take care of many patients who've had heart attacks or strokes, and lipoprotein(a) is a very common explanation for heart disease that runs in the family. So this graphic kind of gives you some detail about that. So let's do a quick family tree here. This is you, and you've got a brother, Tony, and a sister, Jess. Your parents, your father had a heart attack at 44, mom, nothing, no troubles. Your father's sister, good old Aunt Jill, she had a heart attack when she was 57, and Uncle Rich had a heart attack at 48. And then if you go up one more level, grandma had a heart attack when she was 58 here. Grandpa, nothing. So this would be a strong family history of early coronary artery disease. Oh, I forgot Aunt Janice over here. That's grandma's sister, and she had a heart attack too. This would be an example of a very strong family history. So something's going on. In this scenario, I'll ask, were any of the folks who had heart attacks smokers? And if the answer is no, none of them were smokers, then now you're extra worried because there's no other explanation for these people having heart attacks, basically. So in this setting, if it were indeed to be lipoprotein Lille were the culprit, you would more or less have a 50% chance of inheriting the gene. So if you got the lipoprotein Lille gene from your father, then you would end up having high lipoprotein Lille and being at high risk. But it's possible that you did not get the gene, so that would be, then you would not have that risk factor. And in any event, it's more or less a 50% chance. And the same goes for your brother and your sister. Both have 50% chance. So how is it measured? It's done in a blood test, standard blood test. You don't have to be fasting for it. And contributing to some confusion, the measurement values are reported in 2 different units. So some labs report milligrams per deciliter, and others report nanomoles per liter. And that's different assays, different means of measurement. There's some subtleties that go into that. But basically, if your lab does it in milligrams per deciliter, if you multiply that times 2.5, then you'd get the nanomoles per liter value. So while these aren't directly translatable, that's generally how we switch from one unit to the other. And here are the risk levels. So normal would be less than 30 milligrams per deciliter. Medium risk, about a 20% increase in risk. That would be 30 to 50. And these are relative risks. In another video, I'll talk about absolute risks. A high risk lipoprotein Lille would be in this range, 50 to 180 milligrams per deciliter, and then that's a 50% increase in risk. So half again increase in your risk, and the very high level is greater than 180 milligrams per deciliter. And that's a 2 to 3 times risk from where you would be at if you didn't have that problem. So for example, somebody who's 55 and generally in good health and doesn't have any specific medical issues, and their cholesterol is average American, then that person's risk is about 4% over 10 years. And if you've got very elevated lipoprotein Lille, and this multiply by, let's call it 2.5, that becomes a 10%, becomes 10% risk over 10 years. So it's a big difference, actually. And that would be a person who's really at low risk, except for this lipoprotein Lille. So who should have this checked? Basically, in my opinion, all adults should have it done at least once in their lifetime, so you know where you're at. Because if you don't ever have it checked, you just have no idea what it is. If you have no family history at all and there's 0 heart disease in your family ever, then I suppose you wouldn't need to have it checked, but I don't know, that's a pretty rare instance. Okay, so that's lipoprotein Lille, the basics. I'll see you in the next video. I'm going to talk about how to get it checked and then what to do if it's high. See you soon.